Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of MRCP within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam, or indeed medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is toxic epidermal necrolysis. Toxic epidermal necrolysis, or TEN, is a rare life-threatening skin condition involving blistering and peeling of the skin. It's a continuum of SJS, which we discussed in the last presentation. TEN can be diagnosed in people with SJS when more than 30% of the skin surface is affected and mucous membranes are extensively damaged. It can be caused by various stimuli, most commonly medication. If you'd like to hear more about SJS before we move on with this presentation, just click on the link. TEN affects all ages. It is characterized by diffuse erythema of more than 30% coverage of the body, as well as tenderness with epidermal detachment revealing red raw dermis. There is erythroderma in 10% of cases, and a positive Nikolsky sign is seen. These patients are very unwell and are usually pyrexial. History and clinical examination, including orogenital examination, is key, as with any dermatological condition, but particularly, for example, SJS. As with SJS, it's important to exclude septicemia, as well as conducting a chest X-ray as part of this workup. Mycoplasma, HIV and HSV serology should be tested, and a skin biopsy may be done, which would show a subepidermal bully with widespread epidermal necrosis. There is also separation or loss of the entire epidermis. Treatment is largely supportive with good nursing care as per SJS. They may require intensive care or a burns unit, especially if there is evidence of septicemia. Patients with TEN should be investigated for potential triggers, including drugs, and these should be suspended. Patients are usually nursed on an air fluidized bed and will require ample analgesia. Aseptic minimal skin handling is required, as well as fluid replacement and nutritional supplementation. If there is any suspicion of ocular involvement, an urgent ophthalmology referral should be made. There can be certain complications of TEN, which are similar to SJS, and these include dehydration, including AKI, electrolyte loss, protein loss, including hypoalbuminemia, septicemia, inability to eat or drink, scarring, and blindness where there is ocular involvement. With the appropriate treatment, the epidermis will regenerate after 1 month. However, mortality remains at around 30%. So let's try a question. Which of the following can help differentiate TEN from SJS? So our options are degree of epidermal detachment, presence of target lesions on the skin, involvement of mucous membranes, age of the affected individuals, and association with viral infections. So the correct answer in this case is option A, degree of epidermal detachment. You will remember that the thing that differentiates SJS from TEN is the fact that in TEN, more than 30% coverage is seen of the affected skin. Thank you for listening to this episode of Bite-Sized MRCP. If you like what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss our next episode. Let us know in the comments which topics you would like to hear in future. See you in our next episode.